Right, Assalamu alaikum, good morning. Thank you so much for attending. This is the Uveitis session. The session is titled, What Would You Do If You Were in My Shoes? So we'll be starting by several case presentations. I would like, it's Ahmed Salam here from Arkansas, and I would like to welcome the co-moderator, Dr. Hassan Dibi from King Cash Hospital. Our first speaker is Dr. Lilian Karina from Cleveland Clinic, Abu Dhabi. And yes, and she was talking to us about her case very soon.
Thank you for staying in the session. I think I have two cases today about management of patients. This is my very first one. So this is a little girl. She's 8 years old, and she started with non-specific joint pain and one swollen knee. So the parents took her to the rheumatologist, and the pediatric rheumatologist is looking for my help to see if there is anything in the eyes that could point towards juvenile idiopathic arthritis. So I have to look for uveitis. As you can see, the ophthalmic examination is normal, vision is perfect, pressure is perfect, no inflammation in the anterior chamber either eye. However, some pigment of the anterior lens are facing the right eye. And let's see the posterior segment. As you can see here, the left eye is perfectly normal, but something is going on at the inferior posterior segment of the right eye. The vitreous is not a normal vitreous. I will say I describe myself like organized vitreous, like something happened before in this eye. So here you have a better view, and you can see these are not snowballs, but this is like areas of fibrosis and organization of the vitreous. So I called her and I said, I don't think this is related to juvenile idiopathic arthritis because GI uveitis is anterior uveitis. We do not see these kind of things. You can say also that the optic disc is a little bit hyperemic. So she said yes. This is the OCT. Again, normal profile, normal thickness, but if you see the right eye, there is perifoveal thickening. Perifoveal thickening is one form of maculopathy, inflammatory maculopathy. In these little patients, the retinal pigment epithelium is healthy, and it's able to pump liquid from the inner retina in a better way than in adults. So many times you don't see cystoid macular edema. But you can see this kind of perifoveal thickening, which is a way of showing inflammation. So I called her, and I said, I don't see features of juvenile idiopathic arthritis, but something is going on with the girl. So she told me, yeah, all the workup is negative except for HLA-B27. She was positive for HLA-B27. And as you all know, the most common form of uveitis in HLA-B27 is acute anterior uveitis, but this is not the only form of uveitis. The spectrum includes intermediate uveitis, posterior uveitis, retinal vasculitis, and panuveitis. So I decided to go for fluorescein angiography, although she's a little girl, but I think this is needed. And here you are the fluorescein angiography. The left eye is normal, and this is 7.11 minutes in the right eye, and you can see small vessels vasculitis, which is a non-manifestation of HLA-B27 spectrum. So here is the decision. She's 20/20 visual acuity. I show you the macula. So the macula has some inflammation, but she's 20/20. And I didn't see much involvement of the vitreous. I saw like a sequela of uveitis in the vitreous. So it's difficult to take the decision to start treatment, but I decided to start. I called the rheumatologist, and we agreed to start methotrexate for her. We put her on methotrexate. After 3 months, the fluorescein angiography was mostly unchanged, so we decided to add adalimumab. And she was still having some joint issues under methotrexate. So here you are, the initial fluorescein angiography, and this is almost 1 year after the treatment with the combination of adalimumab and methotrexate. So she improved. You can see that we only have some hyperfluorescence at the disc, but all the vasculitis is gone. Her joints are perfect. She's still under treatment, and this is something that the Sycamore study showed, that the children, they respond very well, but then it's not easy to withdraw the medication from them. So at one point, many of these cases, they become chronic patients, and we can spatiate a little bit the medication, but whenever we want to take it out, the inflammation comes back. But her joints are perfect, her vision is still perfect, and she normalized all the ophthalmic examination. So this is my first case, and my shoes were not the most comfortable ones for these patients, but sometimes you have to be patient because we waited a long time until the fluorescein angiography became normal, and we managed to treat her without any systemic corticosteroid. Thank you so much.
We have a few minutes for questions. Dr. Dibi, any questions for Dr. Lilian?
Yeah, thank you, Dr. Karen. It is a great case. It's rare to have such cases like that. The things that I notice, you know, the vasculitis, it's focal vasculitis, but it's not involving whole of the, you know, blood vessels, which is unusual in these cases. What you did is great. You treat them in the times. Also, there is not a lot of signs of uveitis here, but vasculitis is lethal. You know, notice should be treated as you did. I noticed that at the time of remissions, the one that at the optic nerve, it is actually, it's not hot disc that indicating active process. It's mainly remnant, I think so, of a previous either, you know, yeah, no, in the last one, that of the fluorescein angiography, there is only a segmental area of hyperfluorescent, which is not indicating the active process. Questions?
I have a question, Lilian. For how long would you keep her on treatment in a case like this? What's your minimum
I
duration?
don't think there is right and wrong. What I do is I make sure that I have a normal fluorescein angiography. Once I reach that point, I keep the patient 3 months in full treatment, and then I have a conversation with parents and say, let's start taking the medication out. And this is a process. So I start reducing the amount of the dose of methotrexate till I reach like 5 milligrams per week, which is a very low dose. Once this is achieved and there's no rebound on the inflammation, and this means repeating fluorescein angiography, which is not nice for kids. Once I achieve this point, I try my best to put the Humira every 3 weeks. If everything is fine, we go for Humira every 4 weeks. And if a patient is able to be off inflammation every 4 weeks, patient doesn't need the Humira anymore. And we are very happy and we take it out. This is what I want. What it happens many times in kids especially, and this is what the Sycamore showed after 5 years following the kids, is that in the long term and when you are in 3 weeks, they relapse. And I think this is the problem now, especially for kids.
Thank you so much.
I have one more comment, if you don't mind. You are using methotrexate and Humira. What are the indications to have it, to put methotrexate, and then why not to switch it the opposite and start with one medication? Yes. You are using methotrexate plus Humira, okay? How you put it like that? Why you are not giving only one medications?
I have started her on methotrexate, although just to give her a chance. I was not very confident because methotrexate is not the very first indication in HLA-B27 vasculitis. But we gave the chance. He didn't respond. Why I added, instead of just taking out methotrexate and putting Humira, in order not to in order to avoid the development of antibodies against Humira. Because this is the other problem with Humira. And again, it's the only one labeled medication for uveitis. So I want them to be able to keep on the medication and not to have to switch to another one because of antibodies.
Thank you. I think we'll have to move on with the presentation. Next speaker is Dr. Iman Abdulatif from Alexandria University. Dr. Iman. So although Humira is humanized, but you can develop antibodies, you can actually measure the level of Humira, and you can measure the level of antibodies, but it's mainly based on clinical experience. Can we have Dr. Iman's talk, please? Do we have a remote control as well? I'm sorry, I don't know. I think this is the one. Lillian, did you use this one, right? Okay. Yeah.
Thank you very much, Dr. Ahmed, and a very good morning for everybody. Today we will present a case of uveitis and give a fully investigated case. All the labs are positive, all the labs are supportive. Maybe one or two of them will come in handy when you need them. This is a 36-year-old female patient who presented to me, who was referred to me with right atrophia bulbar following a penetrating trauma, a large laceration, and left panuveitis that has been chronic for 3 years despite several medications. This patient had a cold abscess. This is a straightforward case. It's a tuberculous uveitis, but we will show the array of investigations, all of them positive. One or two of them might be new for us, and we can use these tidbits of information in our cases. This is a cold abscess. In my country, where I come from, we do not encounter TB every clinic. We encounter it every single hour. We do have a large TB wave almost for the past 10 years, maybe because of HIV and because of the increased use of shisha, if you know it, the nargila. These tests are well known, the tuberculin tests. One point I'd like to comment on is that the presence of vesicles, we always see redness, we measure the induration, but when you find vesicles in the comment on the tuberculin test, please note that this patient has an excessive reaction to the purified protein derivative, and this patient should not repeat the tuberculin test because of the intense reaction broke down the intercellular septa, so it formed vesicles. If this patient gets the tuberculin repeated, he might develop an intense reaction and might actually die from the hypersensitization. The quantiferon TB gold test is also gaining a lot of popularity, even in developing countries like mine. Then we will come to the key messages I'd like to focus on today. Some lesser known lab investigations that support very strongly that your case is tuberculous, because sometimes the tuberculin test and the quantiferon test are not very conclusive, especially if the patient is on steroids or on immunosuppressives. Serum cortisol. Patients with tuberculous uveitis, in my practice, in my hands, usually have a depressed endogenous cortisol level. You might find the cortisol low in the early morning or in the afternoon or both. The reason is tuberculosis is the second most common cause of adrenal hypofunction. It infiltrates the adrenal cortex, only second in frequency to Addison's disease, the autoimmune adrenalitis. So when you find that the patient's cortisol is low, this favors the diagnosis of tuberculosis. And one of the theories, or one of the rationales that this patient with tuberculous infiltration of the adrenals actually developed uveitis is that because we all have cortisol in our bodies, and this is one of our body's main defense mechanisms against inflammation. But when we are about to develop inflammation, we need an increased amount of cortisol. So the increased demand, a healthy adrenal can cope with, but a sick adrenal and infiltrated adrenal cannot cope with. And this is one of the reasons why some people develop inflammation, while others do have tuberculous infiltration of their adrenals, tuberculous infection of their bodies, but do not actually develop clinically overt inflammation. Another test that might come in handy when you need it is the ESR, the erythrocyte sedimentation rate. Many inflammations, many autoimmune diseases raise the ESR, but you might find it within the range of 50, 60, 70, and ESR above 100, especially in the first hour, highly supports tuberculous infection, active TB. Another cause of a very high ESR is malignancy, cardiac failure, also raises the ESR, but TB is one of the few inflammatory conditions that are able to cause this shooting ESR above 100 in the first hour. A very readily available test is the CBC, the complete blood count. Atypical, this is, by the way, the part of the printout of the same patient, but we would like to emphasize what findings in the CBC, this readily available test, this inexpensive test, support the tuberculous uveitis and why. You find that the lymphocytes, the total number, the absolute number of lymphocytes is increased. The patient with tuberculosis has lymphocytosis. Do the Mycobacterium TB attack the lymphocytes or have any business with the lymphocytes? No. The process which is keeping us all alive and doing well in spite of many infective agents living around us in all the media is known as phagocytosis, one of the key processes of sustaining the human life. Phagocytosis consists of two basic steps. The phagocyte, like the macrophage or any cells that eats the microbes, first engulfs. Okay, one more minute. Okay. First engulfs the microbe, then it attacks it, it kills it inside. But the macrophages cannot kill the tuberculous bacilli, cannot kill the Mycobacterium TB. So they ask for help for interferon gamma from the T helper cell. So the more infected macrophages, the more the T helper cells they proliferate in order to supply the demanded interferon gamma. That's why we get lymphocytosis. This is the T helper cell proliferating, and this is also the basis of the quantiferon TB Gold test. It quantifies the interferon that the macrophages receive from the T helper cell. That's why lymphocytosis supports the diagnosis of TB.
Iman, thank you so much.
Thank you very much.
Sorry, we have to move on because of time. Can we have the next speaker, please? And it's Dr. Fahd Kohail from Morphos, Dubai. We can have a question from the audience as Dr. Fahd is wrapping up. Or if Dr. Hassan wants to say something about the tuberculosis in Saudi Arabia.
Yeah, tuberculosis is, big mimickers a lot of disease, but we have to put it as the first one in our differential diagnosis, especially when have such a case as Dr. Iman called abscess. BBG test and quantiferon now is a basic lab investigations for any patients coming to, especially with granulomatous uveitis.
So I'm going to ask all the non-uveitis specialists in the audience to kind of contribute to this case. So this was back in Sheffield in the United Kingdom. So this is a 25-year-old boy with learning difficulties, and he presents to the medical retina department with reduced vision in his right eye, a 4-week history. Fit and well, no general health problems. His vision is 160 in the right eye and 6.5 in the left eye. Has anybody got some mics, rolling mics, so we can get contributions from the audience? This was his OCT, and this was his color fundus photograph. So you can see there's macular atrophy. And if you look at the OCT, again, you've got loss of the ellipsoid zone and collapse of the outer nuclear layer. And this was his left eye, okay? Now, this picture, I've actually got it from Google Images, so apologies. But essentially, this is how his left eye looked. He's got a solitary lesion in the left eye that's not involving the fovea, but it's very close to the fovea. He's already lost his vision in the right eye due to extensive disease. Vision is 160, and his left eye is now 6.5 with a solitary lesion that's almost involving the fovea, but not quite. So the diagnosis was sepiginous choroiditis. We did a workup. We checked for TB. TB was normal. And he was started on 60 milligrams of oral prednisolone with gastric and bone protection. And then I started him on the same time on 500 milligrams of mycophenolate, because I know it's going to be a chronic problem and he will need to be on immunosuppression long term. And I saw him a week later. Vision is still very good, 6.5. The lesion hasn't got any worse. It's stable. So I reduced it to 50 milligrams and saw him the following week. Again, apologies because I don't have the original photographs, but I really panicked because I reduced him by just 10 milligrams and now the lesion is enlarging. So it's getting bigger. He's got learning difficulties. He's 25, 6.5 vision in the other eye. He's already lost the right eye. So what am I going to do? What did I do next? So if I could have contributions from the non-uveitis specialists. So we have a case of sepiginous that's responded initially very well to 60 milligrams of oral prednisolone. And as soon as I reduce it by 10 milligrams, the lesion gets bigger. So I panic. I'm worried. If I don't get a handle, he will go blind in the left eye. So what did I do next? Can we have the microphone? Where's the microphone, guys? Yes. Okay. So we have a suggestion here, Ozurdex. So it's not unreasonable to give an Ozurdex at the time because it's non-infectious. Is Ozurdex enough? Sorry? Can you give her the microphone? Sorry, I can't hear her. عفوا يا أخت سامح ما سمعتك. Virology, no antiviral.
Biological treatment.
Biological, sorry. No, too early to think of biological treatment. But I did something else. But thank you. So Ozurdex is definitely one thing that I did. What else did I do? What else can you do if you're really worried? You're worried that it's aggressive, or you have a potentially sight-threatening inflammation. It's an option you can consider.
Anti-VEGF?
Anti-VEGF is a good option, but I didn't consider it here because there was no evidence of choroidal neovascular membrane. But I would like to thank the sister for all the contributions. But anybody else on this side want to say? I'll carry on. So my approach was, I actually gave him 2 large doses of intravenous methylprednisolone. The reason why intravenous corticosteroid works well is because you're giving 1,000 milligrams, not 60 milligrams. You're giving 1,000 milligrams. And I gave him 2 weekly doses of intravenous methylprednisolone to really suppress his immune system. My thoughts were, if I can't get this under control, whether we then go to biologics, and the thought I had in my mind was something like rituximab to really suppress the immune system. I also gave him an Ozurdex injection at the same time, and we tapered that oral steroid very, very slowly over the ensuing 6 weeks. And I increased his mycophenolate to 3 grams per day. So again, I don't normally give this amount of mycophenolate. I probably stop at 2 grams, but with him, given the severity, given the situation, I increased it to 3 grams per day. And his visions remain 6.5 over 2 years. And the beauty with some of the OCT machines, particularly those that have registration, is that I could watch his infrared reflectance over time. And I could click between each visit, and his lesion did not shift. And his mum still texts me to this day, even when I left to Dubai, thanking me for the effort that we did at that very early, crucial stage to maintain his vision. Thank you.
Fahd, it's a great case. We were discussing between me and Dr. Hassan here is when you go to 3 gram, you get GIT irritation.
Yes.
Sometimes, and more diarrhea.
Correct.
And Dr. Hassan was saying about the mycophenolic acid as a way of reducing side effects.
I did warn him about that, and fortunately he tolerated it, but that was going to be the option. And then the other thought was, if this didn't work and he progressed despite, I'd already contacted my rheumatologist to think about getting rituximab, and just hoping that my hospital will pay for it free of charge, because it's a very precarious situation when it's juxtaposed like that.
Thank you so much, Fahd.
Thank you.
Can we have our next speaker, Dr. Rupesh Agarwal, and we can have a question from the audience as we're setting up. Dr. Hassan? I apologize. It's Dr. Sorry, Dr. Rupesh. It's Dr. Hassan Hasid. I apologize.
Assalamu alaikum. Good morning, everyone. Dr. Ahmed, thank you to moderate this session, Dr. Hassan Dibi. I will present one case which has a long history follow-up in our department with all specialty. This case has come to the emergency with the right eye, sudden loss of vision post-trauma. Patient has the right eye uveal prolapse and vitreous prolapse. Left eye has blue sclera. The history of the patient has recurrent of bilateral scleritis, old history of nasolacriminal duct obstruction, hoarseness of the voice, cough. The differential diagnosis for the patient was clearly we should go for these systemic diseases, Wagner disease or generalized granulomatosis polyangiitis, relapsing polychondritis. The patient was diagnosed by Wagner disease and admitted for surgery as an emergency for scleral patch. You can see post-op image. The patient was confirmedly diagnosed by the biopsy for the granulomatous polyangiitis, and also he underwent another surgery for conjunctival resuturing. The patient was received the induction treatment for the disease by systemic cyclophosphamide and steroid, and discharged for by the maintenance according to rheumatologist. The patient came back 2 months later. You can see dehiscence of the wound and uveal prolapse. According to the rheumatologist, the patient was under remission, but for us there is active disease. We could expect that it could be, this is maybe rejection for the scleral patch. Again, we underwent a second, you can go back on, second surgery for the patient. Can just make the video on? The video, can you make it on, please? Yeah. Here, dissection and preparing the bed for the graft, fixation points for the posterior edge of the graft, using the glue to fix the graft to cover all the area. Most important, tenon to feeding the graft to save the graft. Then gluing the conjunctival, and also use cryopreserved amniotic membrane to reduce inflammatory reaction for the patients. And here the patient is stable after 2 weeks. You can see the image. Patient came back 1 month later by exposure of the graft, again, adhesions of the wound. From our side, we discussed the case with the rheumatologist. We expect that it could be, this is maybe, we increase the systemic treatment, steroid, and the third patient, resuturing for the conjunctival, we use Vicryl here, not the glue, keeping the vascularization for the graft, and we use the amniotic membrane again to reduce the inflammatory reaction for the patients. As expected, that could be a killer problem. The patient has maybe repeated surgery because of the ulcerative conjunctivitis. This is a very important sign for us. Multiple amniotic membrane. We use even, you can see in the first right image, that we use even superior flap. Just to have a brief about the disease, this disease is GBA, has 30% of the patient has ocular involvement, could be from the eyelid until the optic nerve. Necrotizing scleritis is the indicator for morbidity and mortality for the patient, not just for the sudden loss of vision in the right eye, in the eye of the patient. And generally the treatment by cyclophosphamide and until remission, and should keep for 1 year. In our case, we go and make a review for the case. The patient has active lesion in the skin, so we suggested to go for the biological treatment, and we discussed with the rheumatologist according to this study. So the patient received the rituximab and underwent the third scleral graft. And you can see after the treatment, 1 month just, the patient healed, has the skin lesion healed. And here is the post-op. We don't have the video for the third surgery. We use here half of the sclera, and the same the feeding of the graft is the most important. And here the patient 2 years later is stable. Just to conclude, the rituximab is in the refractory necrotizing cases, and the GBA is very important. And repeating graft, in this case you can see 3 cases. In the end we have success result. Thank you very much.
Dr. Hassan, it's a great case, and most of these cases usually not picked from the early, especially by ophthalmologists. They keeping giving topical medications while the patient and the disease is active. I remember one case, Dr. The patient lost one of her eyes because the ophthalmologist not picking the diagnosis, which is symbols. Treatment is an obvious in these cases. Rheumatologist is the main, physician should take care. I think cyclophosphamide in these cases is very effective. Rituximab is really working, but still the level of evidence is good, but not reaching the cyclophosphamide because this is life-threatening conditions.
The patient here, thank you, Dr. Hassan, for this comment. The patient was admitted and always in the rheumatologist receiving the cyclophosphamide, even azathioprine, even the steroid, methylprednisolone sometimes, and according to him, he was stable. But for us, we review the data. The patient from ocular problem is from systemic problem because he has an ANT problem, he was stable. But from the ocular signs, we suggest that there could be active, especially the ulcerative conjunctivitis. This is one of the activity sign for the GBA. So when he received rituximab, you saw everything is stable, and patient maybe for 5 years there is no complaint. In refractory necrotizing scleritis, rituximab is advised for the treatment.
No, we know that for scleritis, rituximab is one of the best biologics to be used, actually. Anyway, your surgical intervention, I know this is a challenging case, but you did great, scleral patch, and trying to save the eye as much as you can.
In the end was save the
Thank you, Dr. Hassan. We'll move to the second presenters.
I'm sorry, I made a mess, so I do apologize. I think we'll follow the schedule. Our next speaker is Dr. Lillian Kareen again, and then after that we'll have Dr. Rupesh Agarwal to follow the schedule. I think the message to take home from Dr. Hassan's case is that if you have a severe sight-threatening inflammation, i.e. central retinal vasculitis or an impending perforation, it's cyclophosphamide or rituximab. There's no time to start Cellcept or Humira. These need weeks to kick in. You have to have like something kicking in like now. So remember, cyclophosphamide, rituximab. Also ocular cicatricial pemphigoid, which is bad because in no time all the fornices are going to be gone. Thank you, Dr. Karina. Nice shoes.
So my second pair of shoes is more comfortable and easier to manage. So in the hospital where I come from, many times we just run these kind of pictures for diabetic patients. We analyze them, and if there is no diabetes, a nurse calls the patient, says, everything is fine, we will run the pictures for you next year, and we are not seeing the patient. And this was the case of my patient in 2016. He was there just for his pictures, no diabetic retinopathy. My nurse called him, and she said, pictures next year. And see what happened in 2017, same patient. No diabetic retinopathy. I don't see a pointer, but something is going on here. Look at these vessels. So in the pictures, we can see mainly in the right eye, excuse me, but a little bit in the left, areas of segmental venous sheathing. So I said to the nurse, call him, because this is new. This was not present in 2016, so we have to see him. He came to the office, nothing about inflammation, 20/20 visual acuity. He was feeling well, no anterior chamber cells, no vitritis. And this is a normal OCT. So this was a finding. And if we are going to be very strict, and I see only this, and there are no other signs of inflammation, to one level, I cannot call this vasculitis. But I told him, listen, we can only observe, and I can continue making pictures of your retina, maybe every 6 months or 3 months, or we can start treatment, because this was not there 1 year ago. So something is going on with you. So we decided for a consultation with rheumatology, and everything was fine. We couldn't find anything. So he said to me, Karina, let's try something to see if this disappears. So I started him on methotrexate, because I said to myself, it's a quite safe medication, it's well known, it's an old one, so let's start the treatment. This is his fluorescein angiography just before starting. So the fluorescein angiography is showing signs. You can tell me we don't have a fluorescein angiography from 2016, which is true, but in 2016, the pictures were normal. So this is baseline. We decided to start methotrexate, and at this point, the only signs were the eyes. And this is in 2021. I saw him last week. He's off treatment, so he cleared everything. This is at the periphery of the right eye. You have an area of RPE alteration. This was present from before and is unrelated to the vasculitis. So I told him everything is fine. We discontinued the drug already in beginning of 2021, and I saw him last week. But what happened? He started having some issues, some pain in his joints. So he went back to the rheumatologist, now completely off methotrexate, and now he's positive for double-stranded DNA suggestive of lupus. So what I saw was the very first sign of lupus. And here is the question, should we treat every time we see only inflammation? Of course, I think we did well running a complete workup by the rheumatologist, but the rheumatologist said from our side there's nothing to be treated, this patient is doing well. So us as ophthalmologists or uveitis specialists, 20/20 visual acuity, normal OCT, no signs of inflammation, only venous sheathing, should we treat or not? Thank you very much.
It's a great case, and I think, can we have a show of hands from those who would treat based on the fluorescein and the clinical picture, and a show of hand of who would just watch it because the patient is not symptomatic?
Yeah, because in this case, everything went fine. But what happened if I am treating and he develops, let's say, hepatic toxicity because of methotrexate? Someone can say why you put him on methotrexate. The vision was 20/20. So I am not sure if I did the right thing. So
I think there's no right or wrong, right? And it's a discussion with patients. Can you use the mic? I think there was a mic there.
I think these are difficult cases, and I agree with you with the vision being good and the risks and benefits. You don't want to just start somebody on immunosuppression. So sometimes what I'll do with a situation like this, where the vision is good, the visual field is normal, everything is okay, the patient doesn't want me to start them on treatment, I sometimes just get electrodiagnostics and look for some kind of evidence of rod cone dysfunction or some kind of delay in the implicit time, and I say, look, there is some impact on the retinal function. What do you want to do? And then often patients say, you know what, treat me. And then you repeat it, and then you actually see there's an improvement, and then you think you're making a difference. I was more relaxed about retinal vasculitis until there was a good paper by, I'm sure Hassan's going to, by, is it Rick Spade, where he showed over time that they do get capillary dropout. So I've become much more, in my career as a uveitis specialist, I've become much more humbled by the impact. And also in Sheffield, where I used to work, I had seen cases being delayed with delayed treatment, where they'd permanently lost vision in one eye with very mild vasculitis in the left eye. So I've become, if you're going to observe, you need to monitor them closely. I don't think it's unreasonable to observe. If you're going to do that, you need to monitor them closely. But I think you've done a really great job with this case.
Yeah, really it's a great case, but vasculitis is one of the essential signs that we cannot neglect it at all. You need the investigation systemically. This could be associated with systemic disease. Treatment, there is an active lesion despite the visual acuity. It is not macular edema with good vision, so that to leave. Vasculitis seems that it's a part of CNS, vasculitis. So treatment with the methotrexate or short course of steroid is not going to affect badly the patients. But leaving vasculitis might be progress, and leading to occlusive vasculitis might lead to further sequelae in the macula itself. So the traditional, classic teaching, vasculitis need to be. This is bilateral, actually. It's not unilateral. So this is one of the strong evidence that for you to treat. But otherwise, if you closely observe the patient.
And I think he was feeling well systemically all these years because of the methotrexate. Because as soon as we discontinue, 1 month after, he said, oh, now I have pain here, there, and they found a disease. So what I saw at the beginning was the first manifestation of his lupus, actually.
Thank you, Dr.
Thank you.
Our next speaker is Dr. Rupesh Agarwal from Singapore. Dr. Agarwal, thank you so much.
Thank you. Once again, thanks to MUM, thanks to Dr. Hassan and everyone for having me here. This is how we, okay, thanks. Just to give a quick comment about the retinal vasculitis. Through IUSG with Professor James Rosenbaum as the chair, he presented a very beautiful talk on retinal vasculitis about the systemic association. We are starting a study called as Revise. No, it's right. It's right. My first slide is that. Organizers asked me to put up this as a first slide. Yeah, okay. That's my first slide. Yeah. So we are starting a study called as Revise, is retinal vasculitis study, and where we'll be investigating evidence-based, experience-driven 1,000 cases of retinal vasculitis to come to some of those things. Hopefully, we'll be answering that in next 5 years. Okay. So let's see. This is a 26-year-old Chinese male. Now, this is a case which can come to anyone here, non-uveitis particularly. To watch out for what all happened over the period of time. I'll try to finish it in 4 minutes. Floaters, headache, followed by floaters, followed by blurring of the vision, followed by pain on the eye movement. This is before he came. Therefore, day -3, -2, -1. Saw an eye specialist, diagnosed papilledema on direct ophthalmoscope. Okay? Referred to my hospital, massive papilledema. You see that clinic. And then patient was diagnosed papilledema, admitted under neurology care, based on direct ophthalmoscopy, commenced on IV methylprednisolone. Now, after they thought maybe optic neuritis, someone wanted to examine the retina. I think someone dilated finally, and after they dilated, slightly bigger picture. When you have that 30-degree picture, now you got 45-degree. You can see something happening there in the infratemporal retina along the retinal vessel, as was shown by the previous speaker also. Now you go a little bit more peripheral. You see something happening there. So you have optic neuritis or papilledema, whatever you want to call it as, and then you got peripheral involvement. So, dear friends, this is a patient with optic nerve as a secondary involvement, but probably there was a primary retinal involvement, and we then went into the detailed history, and eventually when the patient was started on IV methylprednisolone, and then they realized quickly maybe they are wrong, they have not investigated enough, or they haven't seen the patient, then they refer to Uveitis clinic, and we at Uveitis clinic diagnosed the patient as chorioretinitis or retinitis with retinal vasculitis, probably infective, probably inflammatory, but always in Asian context is the infective first, followed by the inflammatory. We went through the standard investigation which we do, a fundus fluorescein angiogram, certain blood test which we always do. Syphilis came out positive. Now, is it syphilis? So the patient underwent a syphilis treatment. No, cannot move behind. Okay. And then the patient was under close observation. Now, how close is close, we don't know. But under every day I was seeing. But that day 7 and day 8 was Saturday and Sunday, and I would have gone for some conference. Then I came back on Monday, saw this increasing retinitis patch all throughout. Now, what's happening? We are treating the patient with syphilis. Patient was first treated as inflammatory, then syphilis, now this. Then the diagnosis was changed to progressive outer retinal necrosis. Patient underwent a vitreous or a AC tap, if I remember correctly. Given an intravitreal foscarnate with oral acyclovir, patient started responding. Tetraplex PCR was positive for HSV. So there was a HSV retinitis presenting with retinitis, with vasculitis, with optic neuritis. Now started doing very well. This is the picture which was getting worse and worse, but eventually responded very well. Again, mistake number 3. Patient did very well, was responding 6:45. We thought, okay, we have conquered, kept on maintenance, antiviral treatment, maintenance, steroids, and some topical drops. Vision crashed again on day 27. What would have happened here? Patient had retinal detachment. Following, even though we were good, patient detached retina, we did not do the laser. Now, I don't know whether we should have done the laser or not. That's a controversial thing, still in the literature. And then patient underwent. So this is the snapshot of how the patient progressed in 30 days, starting with optic nerve edema to the retinal detachment and how patient underwent surgery. So, learning points at the stroke of 0 minute, I'll just finish, is a dilated fundus examination is essential in any patient with a disc swelling, and for uveitis in particular, always rule out infective causes first, and it might require a multidisciplinary management. Thank you very much.
So the IgG was positive, right? So he probably had syphilis at some point. Was RPR done and was
RPR
high?
was, we do both the test, IgG and RPR always.
So the RPR was high?
High as well.
So he had mixed infection, right?
Yes. RPR
Okay,
was
was
positive.
this patient HIV positive?
Negative. Negative.
Negative. So it's interesting that you have mixed infection really with the without HIV. So what made you think that this is
The
viral
progress,
retinitis?
because syphilis is known to respond very well to intravenous or the intramuscular penicillin, and they really 100% patients they respond once you pick it up. Now I was very relaxed when I got the diagnosis of syphilis. I said, okay, that's it, we are managed, and patient started responding, but after that it started getting worse, which is very atypical for syphilis to do that. So there might be a concurrent syphilis which is happening, but probably in the eye, when I suspected this is something else, that was because it was getting worse with the syphilis treatment. And that's the only thing. It never happens with syphilis treatment.
Born is one of the tough situations, but we saw these cases mainly in the immunocompromised patients. And it seems your patient is not that status, right?
No, he was immunocompetent, But one thing which we are doing of late in some patients, selected patient, is a bone marrow in some of this thing. And when you see, there is an altered immunological profile when you do a bone marrow thing, and they have some kind of a immunocompromised situation. HIV is negative, everything is okay, but there is a very certain degree of immunogenicity in that, and certain types of immune cells which are low, and it can only be picked up on the bone marrow. But it is a very invasive test to be done. I don't advocate, and please don't go home and say, okay, I'm going to do bone marrow for everything. It's a very, very invasive test. But very selected patients, only 3 patients we have done bone marrow. All 3 patients had HSV1 positive, and when HSV1 comes positive, there is something happening in the body, and that's where probably it might pick up.
Yeah. Do you suggest to have, PCR, Vitreous or AC tab? He did. Okay.
We did. Yeah.
Can I ask you something, Dr. Rupesh? So if I close my eye and think of this story, a syphilis patient, IgG positive, RPR high, guest treatment is getting worse, I would think this is a Jerish-Hixheimer reaction. So how can you teach us that this is not a Jerish-Hixheimer and it's actually think of another pathology?
Correct. That's again a very good question. And if the patient only was on anti-syphilis treatment and no steroid, I would have thought that's a Jerish-Hixheimer reaction both in TB as well as in this. But in this particular case, the steroid was on. He received intravenous steroids, followed by a patient was on tapering dose of oral steroid. So while the patient was receiving syphilis treatment, he was also getting 60 milligram oral steroid. So it is very unlikely that a reaction will happen when the patient, if he was not on, that would have been our first thing. That is one. Number 2, when the Jerish-Hixheimer reaction happens, in a unifocal lesion, the lesion size will increase, the reaction will increase, the vitritis will increase, but multi-confluencity will not happen, the multiple lesions will not take place usually, and you will not get a new lesion suddenly coming up and cropping up. So there were crops of new lesions, which was something which was made us worried, and again, patient was on steroid. So these 2 were probably there.
You have, but okay, no problems. Then we'll follow. Yeah. Okay. Could you put a second presentation for Dr. Robish?
My second one. Sorry, it was in the last, but I just thought I'm here, might as well just present. So this is again a simpler case. I've got one more. Okay, great, thank you. So this is again coming from my clinic, and a pleasant patient, 43-year-old, teaches in a polytechnic, very good historian. So very rarely we get some patients like that, had a LASIK done, comes and very, very clear in her history, presented with visual disturbance of 2 days, worsening since last visit, says that side vision also affected. Now side vision affected, says some flickering of the lights with candlelight flickering persistently present. You have to believe that patient because the ways he described, because some of the patients they just describe as a symptom, and with some retrobulbar discomfort, no recent history of any flu, URTI, or any worsening of floaters, no vaccinations recently. So this is another thing which I've added in my list of history, is about any recent vaccinations and all. So when you examine this patient, no vitreous cells, no anterior chamber cells, but there was a mottled appearance of the macula with some form of vascular attenuation, very subtle, and I will show you the picture why I say that. But when you do the color vision chart, only thing was that she was a bit slow in reading. It was not that they were incomplete, but again, as I said at the beginning, the patient was a very good, the way they presented, and you have to believe the patient. When you look into this, as we have shown in the previous case, one of the cases, it looks quite normal, except one chorioretinal scar. Otherwise, everything looks okay. Not so high myopic, probably moderate myopia. I don't remember pre-LASIK how was it. Now, you do quickly Amsler, which I love doing it, Amsler chart. I have not got the picture of it, Amsler, I got some indication. I try to do Amsler, very simple in the clinics, immediately you can do. And we did a visual field. So this seems to be an enlarged blind spot in the right eye. Now, this is something which I really want everyone to take home point. you look into it, a lot of people will say abnormal or normal OCT examination because there is no fluid and all. But you look into that ellipsoid zone, and particularly near the disc, you see complete disruption of the ellipsoid zone in the right eye, and you compare with the nasal, the temporal part, and then they compare with the other part. The pointer is not working in the sense of otherwise I would have shown you. But you see the other eye. It is very, very important, whether you talk about hydroxychloroquine, whether you talk about some of the uveitis case, to look into those ellipsoid zone when the patient is presenting with those photopsias, with those scotomas and all. Now this fundus autofluorescence is really, I love it. You can see that the way the fundus autofluorescence shows this picture, you can see this hyperfluorescence on the right eye. And when you do a FFA, based on that, you've done a Amsler, you've done a visual field, you've done a autofluorescence, and then you see this Amsler, you can see the patchy vasculitis, other eyes is normal. We have very good electrophysiology with us. Fortunately, I don't think everyone will have it, but we have Professor Graham Holder with us, and he was very happy to do the visual field electrophysiology immediately, and we managed to pick it up. There are certain things which are happening. So to sum up, there was a visual field defect, there is a autofluorescence problem, there was a problem on the SPOCT, there was a problem on the FA, and again, we thought probably let's just do some of the basic tests. Again, IgG, RPR was negative, TBT spot was negative. This is the electrodiagnostic report. I'm going to just summarize for you. There was problem in the right eye, but as well as the problem in the left eye, which was looking normal. Now, this is the beauty about doing ERG or the electrophysiology is you can pick up some of the subtle things. So the diagnosis here was acute idiopathic enlarged blind spot syndrome. I'm not going to go because of the limited time versus azure versus acute idiopathic blind spot versus mutes. How do you differentiate one from each other? A lot of people will think are the spectrum of the same thing, but probably it was acute idiopathic blind spot syndrome going into the azure spectrum. So the options with us was observe. Second was to give high-dose methylprednisolone. Third was to give antiviral, though no level of evidence. Or fourth was to give antiviral with intravenous methylprednisolone. People will ask, why antiviral? I don't know, but a lot of it, probably there is some hidden. A patient being very educated, we discussed. Patient wanted to go for maximal therapy. Patient received intravenous methylprednisolone and oral steroid followed by that. And here, we really want you to see the resolution of the ISOS junction. After 1 month of this, and ERG started getting better, and the patient was kept on oral steroid and azathioprine. Now, this is remarkable. Blind spot at the presentation, enlarged blind spot, you see over a period of 1 year how the patient has resolved in the terms of blind spot just with minimum medication, not so maximum. And here you can see the restoration of the ellipsoid zone. Beautifully, it was distorted, but again, it become completely normal. Sorry for overshooting the time. Thanks again for giving me the opportunity.
Yeah, thank you. This is not an easy case. And most of the time it's challenging to reach, at least some type of diagnosis of, azure or acute, macular. This is not easy case, but I think you manage it well.
Thank you.
Did the patient have photopsia?
Yes.
Or shimmering? Yeah.
Rather,
sorry, I've missed that.
In one of these patients, this is one of the rare patients where we could quantify the photopsia based on the patient symptom. She will say, today I have 20% of my daytime with photopsias. Next day she said she will have 15% of the time she was able to quantify. We are not so fortunate to get such a good historian. In this patient, in this particular case, it was very much helped by the patient. And as soon as she get a repeat increased photopsia, she will come back to me. And typically in this patient, I give them my number and all. Very rarely, don't have to give to every single patient, but this kind of patient, you can give them your email and all, because you need to maintain that close connect with this kind of patient, because you never know when this patient will relapse. The last thing which you want is they call up the clinic says doctor has gone overseas for a conference, is attending Chicago meeting, after that Dubai meeting. I think it's not going to help this patient. You really want to stay connected with this patient. So in this patient, that was the thing which helped us. So I think that's another point which I wanted to kind of give for some of these complex patients.
Thank you. We'll move for the next patient. Dr. Ahmed Salam will be our speaker. And we'll know that Dr. Ahmed is really a senior consultant in uveitis, as well in the as vitreoretinal surgeons. Dr. Ahmed?
Thank you so much, Dr. Dibi. Just a quick comment on the previous case for the audience to summarize. So female unilateral photopsia, enlarged visual field defect, and something in the outer retina you need to be thinking of azure. So remember that combination, because that will help you diagnose azure in the future. So I'll be presenting a case here, which I would like to acknowledge my fellow and my previous resident for this case. This is a 17-year-old gentleman who comes with severe headache and optic nerve swelling, a black spot in the infranasal quadrant of the visual field, and as well as vomiting. He's slightly overweight. And medical history, nothing revealing, very mild myopia. At that time, we did not ask him about whether he was sexually active or not, which is important in this context because we had family in the room, and I think that was missed, really. Visual acuity, we have good visual acuity here. Anti-astigmatic examination, as we'll see, had some cells in the right eye. Intraocular pressure was normal, and the color vision was slightly decreased in the right eye. This is here the anti-examination. What you take from this is very mild subconjunctival hemorrhage in both eyes, as well as anti-chamber reaction more on the right side. Let's see the fundus picture. Here is the fundus picture, right and left eye. And here's a close-up on the right side and a close-up on the left side. This is the autofluorescence here, and you can see lesions in the macula and perimacular or perifoveal in the left side. This is the fluorescein here of the right eye and of the left. You can see the lesion is hypofluorescence early and hyperfluorescent late with disc leakage. And this is the left eye. So we got ICG. ICG is very helpful, and you can see here there's a choroidal lesions going on, as you can see here on the ICG. And that's the ICG of the right. And you can see the lesions are different in size, and some of them are geographical, not all of them are rounded, and that's important. And that's the left eye ICG here. Less lesions and irregular in size and geographical in appearance. So, and this is his OCT here. I'm sorry, it's hidden by my picture. But in the right eye, he has significant outer retinal changes. I'm sorry, but you can take my word for it. Okay, so what are we dealing with? So far, we know from ICG, which is very helpful, that we're dealing with a panuveitis, and it's mainly a choriocapillaritis based on the ICG. So we diagnosed that with a placoid chorioretinopathy. This is here the differential diagnosis. You want to be considering inflammation, infection, and masquerade, and that's the whole list here. You need now to exclude infection. Syphilis and TB are the most important because of the disc swelling and the emesis. He also had, before seeing us, he had lumbar puncture that was slightly high. Sorry, I have repetition. Okay, so everything was negative, and we diagnosed this case of acute multifocal posterior pigment epitheliopathy. His severe headache was intriguing for us, and we know that MP can have cerebral vasculitis, so we had an MRI and MRA, but that was non-revealing. And to summarize this case, we had a patient on steroids, and we were thinking this is going to be self-limiting. And as we tapered the steroids, the patient went on to have another flare-up with new lesions. So he returned again with everything again, back again. So, and this is here a serial pictures of the case. So at this case, we revised the diagnosis to be like a recurrent MP, and there's a name for that, and it's called amphigenous choroiditis, which is basically a recurrent, more severe MP. So here, that was at the presentation. That's after treatment here, and we introduced methotrexate. And I just want to introduce you to this term, which is called amphigenous choroiditis, which is really like the name for when it's recurrent and a more aggressive MP. But very important in this case, we had a very similar case that was syphilitic, to exclude syphilis and TB in every MP or serpiginous choroiditis. Thank you.
Thank you, Dr. Ahmed. You know, AMBI or AMBI-like amphigenous, it is really wide spectrum of the disease. And be well known that it's not that an aggressive disease and can be picked early, responding very well to the treatment. But the cases of indigenous usually is not that case. So you pick it early. We have difficulties sometimes to reach diagnosis of this, but working the patient, ruling out the infectious is the most important, because sometimes herpes-like or TB, it could be one of the differential diagnoses and could be looks like, you know. So really, my questions in this case is, I saw the view is very clear, you know, Uveitis, the disc and these areas of deep, you know, multifocal choroiditis. ICG, it's helpful, and in spot diagnosis, and even though I think so, the monitoring of the patient. So did you repeat the ICG for this patient when you start the medications?
When we restarted them on medications, we did not repeat the ICG because we could see the lesions recurring there. So we just started him on steroids and methotrexate, and usually when we start immunosuppression, we leave them on treatment for about 2 years post-remission. So we don't stop any treatment before 2 years post-remission. And we just stopped his treatment like a few months back, and he's doing well.
Dr. Robish?
I think
It's okay working.
very interesting case. I have a theory and a hypothesis about this as a spectrum of choroidal involvement, and where you put in from inflammatory to infective component. Now, this spectrum is, on one end of the spectrum is serpiginous or serpiginous-like choroiditis, which is like an inflammatory kind of thing where you go for more steroid, intravenous methylprednisolone. And on one end of the spectrum is choroidal granuloma, where you see a granuloma, and there you can only give anti-TB therapy or a very specific therapy. But in between this spectrum, there are three things which comes, is multifocal choroiditis, then you get APMPP, and then you get empygenous. Now, on the top of this is APMPP or empygenous, which can be inflammatory, infective, but typically it is more of inflammatory. And then during the process, if you think some infective markers comes up, and then you might have to treat. So this is the spectrum, and this is beautiful. And sometimes it starts with MP, then it converts into empygenous, and sometimes the empygenous converts it into serpiginous. But that's the kind of evolution which we need to see. I think very beautifully shown.
In addition to what you said, you know, the extremely is that we have relentless types,
Yes.
which is very aggressive. Most of the time is not responding, ended by, you know, multiple colorectal scars, and it is lethal to decrease visions, even though that if you keep this patient in very aggressive course of treatment. Thank you. I think this is my time.
Yes, yes. Our next speaker is Dr. Hassan Adibi from KCASH, Saudi Arabia. Dr. Hassan is a senior VR and uveitis consultant. Dr. Hassan, thank you.
Yeah, thank you, Dr. Ahmed, for your. It is interesting sessions, and we have really challenging cases, but we have, you know, messages. And what would you do if you are in my shoes? This is the time where most of the uveitis specialists on the stage. Can you start my case or presentation? Hassan Al-Dibi is written ASSP. So don't calculate this time, Dr. Ahmed.
Yes. Here we go.
So I'm going to share this case with you of a 59-year-old male known to have DM presented to the ER with history of pain, redness, blurry vision associated with on and off headache started 4 days before coming to the emergency. His past ocular surgery is negative for trauma or previous ocular surgery and negative for similar previous attacks. Systemically, he's having positive history of traveling to Africa. Last one was 1 year and a half. And positive history of contact with cats. Positive history with history of skin rashes after visiting a poor neighborhood in Mecca that recently. And negative history of sexual contact. His ocular examinations, almost normal, with vision of right 20/70 in the right eye, and right eye showing deep with 3+ cells, and no neovascularization or iris nodules or posterior synechiae, and having early cataracts that compatible with his age, and his vitreous show just only anterior vitreous cells. His ocular examinations, fundus exam, show these large lesions in the periphery with equally NBDR in both eyes. When looking for these lesions, having some hyperpigmented lesion inside the large with sclerosed blood vessel inside. So his autofluorescent shows just only homogeneous faint hyperfluorescent. This is just close, and you see this is the hyperpigmented area in the same of the lesion with the sclerosed blood vessels and surrounding with deep yellowish. So what will be the differential diagnosis here? Because of the time, I will go with it. So we put that circumscribed choroidal hemangioma, solitary choroidal granuloma, posterior scleritis, choroidal osteoma, and of course, Uveitis muscaridine syndrome should be involved, like, metastasis, lymphoma, syphilis, and in the same times, infectious causes like acute retinal necrosis or toxoplasmosis could be involved in such differential diagnosis. The fluorescent angiography showed an early hypofluorescent in this area with, NBDR signs in the fluorescent angiography. Then that increased with the hyperfluorescent at the periphery of this ring. Then having hyperfluorescence with the staining and the most of the lesions with homogeneous hyperfluorescent in the center of that. OCT was really showed vitritis with actually involvement of the outer and inner retina with loss of ellipsoid zones and nodulity at the RBE levels. So B scan showed no things, and his CT scan showed 1 centimeter solitary semi-solid nodules in the anterior segment of the right upper lung, surrounded by ground glass, and the differential was to rule infectious or neoplastic. So the patient woke up, and during that we dig in the history of the patient. He told us that he's having, this skin, the hand, the palms rashes, with papillomacular rashes, which is dry in this stage. So working with the patient showed that positive, negative basic workup, positive IgG for toxoplasma, and anti-tripanoma antibodies was positive for IgM and IgG with positive PDR and negative for HIV. So the diagnosis of acute syphilitic posterior placoid choroiditis was my death at this time. The patient referred to the infectious disease to do LB for this patient, more neurosyphilis, and to treatment of the patient with the IV. So the treatment of the patient showed that really improvement in the lesion, if you look that with residual and even though in the OCT of the patients. So this is the lesion pre and post. Treatment I will not give because of the times, but the most important to be aware about ocular syphilis manifestations. And if you look for that, for acute syphilitic, gas was reported that in 1991, it is involving mainly of the macula, it's not involving the peripheral lesions. The diagnosis most of you know, and this is the imaging finding in the patient of the FA. So in summary, acute syphilitic posterior placoid chororetinopathy alert us of acute syphilitic infection. Ophthalmologist plays a vital role in the detections and urgent referral to the infectious disease, specialists starting systemic treatment as soon as possible. If syphilis is promptly recognized and properly treated, it has an excellent functions and prognosis. The treatment is usually by IV methylprednisone as considered as neurosyphilis, but our infectious disease, we prefer to go with the intramuscular procaine penicillin. Thank you, Dr. Ahmed, for giving me this for us.
Thank you so much.
And actually, we are going to say this is an acute syphilitic anterior, not posterior, anterior placoid chororetinopathy.
It's a very nice case, Dr. Divi, very nice. Any questions from the audience on syphilis and syphilis chororetinitis? Please. Do we have a mic there?
I would say one thing before you ask questions. In Saudi Arabia, we really for a long time we don't have cases of syphilis. But we noticed that after the COVID, there is really a peak of these cases. I don't know, it is the same in the Gulf, same in the Egypt?
Well, that was one of my comments that I have seen, I mean, kind of outbreaks of retinal vasculitis, at least in my humble, experience. I am I do oculoplastic surgery and I'm general ophthalmologist to start with. And I have seen this year a lot of cases of retinal vasculitis, unusual for at least the past few other years. I mean, haven't seen that in the general ophthalmology clinic, retinal vasculitis. I thought this could be due to COVID era or post-COVID era. This one thing I want to mention, and I want to also to know if it's your experience as well. The other thing is that I see the cases of retinal vasculitis, especially if it's unilateral, I call it, or I label it as a neuroretinitis, and usually cases come to me with that have been investigated very well, systematically, generally, and rheumatologists looked at it and they didn't find anything. So it's a purely retinal vasculitis isolated. And I start them on steroids, and they do very well in 3 months' time. I have, within 6 months, usually, you can stop the steroids, and they are well. Every time, and I just ask myself whether I'm doing it right or not. I'm not confident, or I don't feel comfortable of using like chemomodulators or chemotherapy or immunomodulation. One of these fancy, I don't have an experience with. And usually the rheumatologist, he would like to have abnormal, let us say, lab result or to follow up the patient on these cases. So they refer them back to us. It has no systemic disease, so do whatever you want. The only armamentarium I got is a systemic steroid, and they do very, very good at the end. The only thing that the patient suffers is the side effects of systemic steroids over the 2 months or 3 months time, like acne and swelling and putting weight and so forth. Am I doing it right, or is there any fallacies or any, what's the advice?
Yeah, thank you so much it's a great question. I think it needs to be longer treatment, and the problem with systemic steroid is the side effects. So my advice would be to refer this case to someone who's dealing with uveitis so that they can go on immunomodulation, because usually they need longer treatment. Thank you so much. Okay, well, thank you so much, Dr. Dibi. Thank you. And our last speaker is Dr. Hassan Hasid again for his case presentation.
Thank you again to keep with us until the last. The last case for me is a baby in the ICU with postmenstrual age is 33 weeks. The weight is 1100 and gestation is 29, and the birth weight was 900, around 900. Patient was intubated for RDS and an annual situation. So he requested ROB examination, screening, and eye examination because the patient has septicemia. Left eye examination, lens vasculosa, and you can see the fundus visible in zone 2. Right eye patient has KB's moderate size, and he has inflammatory membrane in the pupillary area, and he has even visual sheathing on the iris. Fundus is not clear. You can see kind of multiple area of retinitis, choroiditis, and ultrasound. You can see vitreous opacities and thickening in the chorioretinal layers, and he has infiltration in the temporal area. So here you should go and review the case from the beginning, because from the first day the patient was under antibiotics, And just let me summarize. The patient from the beginning has respiratory infection under the antibiotics without increase. You can see just the procalcitonin was elevated in spite of antibiotics. So they do the culturing. Patient has urinary positive urinary infection for candida. He received fluconazole, but still eradicated by amphotericin systemically. In the third week, the baby developed septicemia by Klebsiella, and he has sign of meningitis according to the culture of the CSF. So for us here you can see patient in RDS, neonatal thrombocytopenia, anemia, suspected urinary infection, bacterial septicemia by Klebsiella, and meningitis. So you have it could be causing for the yeast or for the bacteria Klebsiella. So as there is infiltration, there was some suggestion to wait, but for us we saw that the patient was unwell from the beginning, and now we was septicemia today. In that time he has meningitis, and vitreous was already involved, so we decided to go for vitreous tab and intravitreal injection. We choose the two medication which was sensitivity according to the lab. We choose the ceftazidime and amphotericin B. Second day after the injection, you can see huge improvement in the anterior segment and decrease in the infiltration in the posterior bole. 5 later, gradually decrease in the size of the infiltration, and around 1 month later, the patient has developed the scar and the pigmentary in the posterior bole. The history didn't finish here. 2 months later, the patient developed type 1 ROB, which need laser. So we treat him by the laser, and 10 months later, the patient has a stable situation, has -7 in the right eye because of the anterior segment ischemia related for the infection, left eye stable. Just to have a brief about the neonatal endogenous endophthalmitis, sorry, that's covered. The reports from USA between 1998 and 2006, there is decrease by 6% per year because of the good care of the in ICU care, or even use good medication for the antifungal and antibacterial. Candidemia and bacteremia, ROB, low birth weight, or these risk factor for these babies, which requested the patient for regular checkup, fundoscopy. Endogenous endophthalmitis is a rare incidence, but the problem is that has poor outcome, and some cases there is evacuation is the solution. Focal retinal infections is a good prognosis than fulminant cases. When the patient has choroidal infection, you can go for the systemic treatment, just an observation. If the patient has vitreous involvement, you should go for intravitreal injection, and maybe you need the baseline vitrectomy. Yeast is better than, the prognosis of the yeast is better than bacteria, and bacteria is better than molds. And this is a recommended workup for these cases. When you face these cases, you should rule out all the other cases when you deal with this case. Thank you very much.
Dr. Hassan, it was great case. يعني extremely complicated to go to take care of this.
Do you know I'm not a uveitis specialist, but we face this as in our hospital.
I was not find that cases also. I had one case like that ended by,
It's
loss of the eye, and
it's very urgent case, and you need to emergency intervention
but
for
you
these
managed
cases.
it well, because we have next session should be started now. So thank you all, and thank you for attendance of this Uveitis session. Thank you very much. I don't know who is putting. This is not good. This is money, wallahi. شكرا دكتور أحمد. It was great. Cases was very well. Oh yeah, very nice. Good luck, guys.
Remove the seats. All right. All right. So
intentionally with the last cases.
Yes.
Yeah, because we need to show.